Our last speaker is, our last presenter is Dr. Mahipal Sachdev, who is going to talk on utilizing high-tech techniques of now managing dislocated IOLs.
Thank you very much, Dr. Keki. Always a pleasure being in your course. I'll be talking about subluxated cataracts as to how you use the femto laser technique for handling them. Okay, so I'll wish to thank Kumar for this particular video. Okay. So when you're looking at the subluxated cataract, as has been spoken by the earlier speakers, the aim is to preserve the capsular bag and to minimize the vitreous loss, and which allows the placement of a PC IOL. So you have to be prepared when you are working with a subluxated cataract. You need to look at it pre-operatively to see any of these signs. So obvious subluxation, phacodenesis if there is there, increased space between the back of the iris and the lens, and the lens edge can be seen in extreme gauge that is there. Now these are the causes for the subluxation. I'll just skip over it. So what you have to do is that you have to look at the extent of subluxation and the etiology of the subluxation, whether it is progressive or not, and the grade of cataract that you are dealing with. That is what needs to be done. So typically what we do is that we less than 3 clock hours we'll just put a CTR and a 3-piece IOL. The IOL haptics will act. When you're looking at 3 to 6 o'clock, CTR with or a ring fixation or a glued IOL, that is done, and similarly more than that you have to do a glued IOL. Now the challenges that are faced are doing a capsulorhexis, and I think doing a capsulorhexis is one big advantage that the femto cataract does, and even if there is a vitreous, you can get a good capsulorhexis and a complete capsulorhexis. Any discontinuity in the capsular ring is a contraindication for putting a CTR, and therefore that causes a problem. Now also what happens is that there is a continuous vitreous hydration during phacoemulsification, and this causes a communication, and the vitreous keeps on increasing. So what we do is two things that we have done. One is a femto assisted cataract surgery and vitreous decompression. So this is a small pupil, irregular shallow AC. Patient had an attack of angle closure glaucoma. So you can see this is the angle closure glaucoma, and iridotomy had been done. And if you see again, it is a very shallow AC which this patient has. This is the sphincteric atrophy which is there, and you can see that this is a subluxation that is clearly, which is noted here. You can see on the movement that this is a subluxation. You can see that. So it's a hard cataract. Phacodonosis is there. So that is what is this thing. The pupils are not dilating, etc. What is done is that you have to dilate the pupil before you do a capsulotomy. So this is a Malugin ring that has been put, and you can see that there is a bowing forward of the iris while the iris is going down here. So you can see that this is a subluxated cataract. After putting a Malugin ring, you increase the energy level of the laser for doing a capsulotomy, or you can wash away the viscoelastic, put a suture and do that. So you can see this is the position of the Malugin ring, and then you can see that the capsulotomy and the nucleotomy is being done. So despite a subluxated cataract, the femto is going to give you a good capsulotomy. There is going to be a nuclear disassembly that's going to happen, and that helps you because you can easily take away the nuclear fragments which are there. So after this has been done, you can see in this particular case the capsule has been removed. The Malugin ring is still in place, and you can see this procedure is being done. See the mobility because of the subluxation of the cataract which is there. Again, we are trying to rotate at this particular point, but it's not rotating well because there is a forceful hydrodissection was contraindication in this particular case because of the subluxation, but gentle movement that can be done. So at this particular point, because we were not able to rotate, there is a hook that is going to be put, and you can see this hook is being put, which is going to stabilize. Ideal would have been to do a capsular hook, but this is an iris hook that is being used to stabilize the bag. So you can see the bag has been stabilized, and now the nucleus can be disassembled, which has already been pre-cut or pre-chopped by the Femto. So this is the nucleus that is being disassembled. You can see slowly we are able to remove this. There is an upthrust put viscoelastic, and again because of the movement of the capsular bag, a second hook is being implanted. So this second hook is going to keep the capsular bag intact, and then you are doing onto the epinuclear a slow motion phacoemulsification to remove the epinucleus that is being taken out. A bimanual irrigation aspiration is being done, as you can see in this particular case. Once the bimanual irrigation aspiration has been done, a capsular tension ring has been injected. So the golden rule for a CTR in subluxated cataracts is that you should not inject it too early nor inject it too late. So you need to be careful or be sure of your surgical technique as to whether you need a CTR to be put at that particular time, and this is the injection of the lens to give you a good outcome. A 3-piece lens could have been done, and then you can see a vitrectomy is being seen if there is any residual vitreous which is there. Now let us just say what were the advantages. So it was not dependent on zonular counter traction for capsular access. That is the most important thing. If you are doing a needle capsular access, there has to be a counter traction which is there. The entire capsulotomy can be done in a closed chamber, and it allows lens fragmentation without any additional stress on the zonules. Vitreous decompensation, we will just be showing you the next second video, and that's the last video, is that you're using the vitreous decompression from a posterior. Abhay Vasavada has shown that it is always better to do a posterior vitrectomy than an anterior. So you can see this is a doctor who came to us from Patna. You can see a huge subluxation post-traumatic which is there. Examination showed 624 vision. This is what it is. Phacodonosis grade 3, fundus within normal limit. Plan was to do a femto assisted cataract surgery with PCIOL CTR with the vitreous decompression which is there. So this is the picture that you have. I'll just show you the femto which is here. So you can see in this particular case, let's go on to the image of the femto as you get. So just see here, this is all vitreous. Can you make out? This is all vitreous which is there. The iris is going down. We have to readjust the posterior part and the anterior part of the capsule, because this is important to get a good capsulotomy where you want. You can actually, because you are going to put a ring, so you can actually do a capsulotomy. You can do a custom made capsulotomy and increase the size of the capsulotomy so that once the CTR pushes the capsule to one side, it is central. So you can see this is a customized access, and we are increasing the size. And now once the femto is being fired and LRI has been done, so this is the this is what you got in the patient as you go. So you can see this is what we have in this patient, a good capsulotomy. We have the 6 quadrants. You have the vitreous coming out here. So what do we do in this particular case? We put in the trocar, put viscoelastic, put in the trocar, and do a vitreous decompression in this particular case. So you go ahead, whatever liquefied vitreous is coming, we take that out. We go in, as you can see, and remove all this. This is tricot, as you can see. We remove all the vitreous so that the lens shifts and the hydration of the vitreous is not there. You can see there is a huge vitreous tag which is going on towards the wound. A good capsulotomy has happened despite vitreous. You would not have been able to do a capsulotomy. And in this particular, in the last case, I showed you the CTR being put right at the end. In this particular case, we are putting CTR right in the beginning because the zonular dialysis or the subluxation was pretty huge. So again, low slow motion phaco, you can easily take away the nuclear fragments which are there. We have put in the CTR as the first step step, and that is keeping the bag. You can see that the whole bag has tilted and it has become central now, and this is the epinucleus that is going to be taken out in this particular case. Bimanual irrigation aspiration is always safer in these cases. The nucleus is taken out, they put in viscoelastic before taking out the irrigation handpiece, and put a 3-piece intraocular lens which is there, and once the 3-piece intraocular lens is there, you can see that you will get a good outcome in this particular case. Now from the posterior part, again doing a vitrectomy to remove anything, then we will change the hand pieces, the 2 hands, and also look at the anterior part to, this is where the tug is. You can see this tricord has stained this, and we just using a manipulator to get this disengaged. Once you have disengaged this, then you can go ahead and do a vitrectomy, take out the plug, put in fluid from here, and do a vitrectomy from the other side to take this, and that will be completing the particular case of this particular subluxated cataract. This is how the patient looked post-traumatic subluxation, how we were able to use the power of Femto, posterior vitreous decompression, to get great outcomes in this particular case. So this is has been published, limited pars plana vitrectomy for optimizing surgical outcomes in subluxated cataracts undergoing Femto laser, in the journal for in IGO, and this is what we routinely do in case of such particular cases which is there. And this vitreous decompression keeps the entire vitreous down, prevents hydration, gets the lens onto the central part, and you can use CTR. So the take-home message is low fluid settings to prevent surge of fluids into vitreous cavity, tamponade the area of zonular defect with dispersive OVD, femto-assisted capsulotomy reduces the risk of further complication, and vitreous decompensation allows safe phacoemulsification in subluxated cataracts. So difficult situations often yield the best results, and the patients are satisfied with the outcome. Thank you very much for your kind attention.